I'd like to introduce our first speaker, and our first speaker is Dr. Matt Evans. Dr. Matthew Evans earned his degree from Kirksville College of Osteopathic Medicine and completed his internship and residency through Michigan State University in Lansing, Michigan, where he was chief neurology resident. He completed fellowship in EEG and epilepsy at the Cleveland Clinic in Ohio. Dr. Evans is a board-certified neurologist specializing in caring for patients with epilepsy and seizures. He joined the Providence Brain and Spine Institute in 2014 after serving as the assistant director of the MEG and Functional Brain Mapping Center at the Atlantic Neuroscience Institute in Summit, New Jersey. Before earning his doctoral degree, he was an emergency room technician and a whitewater rafting guide in the Grand Canyon. I know, exciting. He assisted in an archaeological expedition in the, how do you say that? Petan Rainforest, Guatemala, and has helped organize numerous outreach medical clinics in the highlands of Guatemala. Dr. Evans is married and has one child. He enjoys fly fishing, telemark skiing, mountain biking, and ultimate frisbee. And Dr. Evans, just to add, is the chair of our professional advisory board for the foundation as well. Welcome. Thank you.
Thank you. Thanks for being here. This is going to be, it's a support for us, and we're glad that so many people are interested in learning more about seizures and epilepsy. Hopefully, I'll lay the foundation for what the rest of the speakers will talk about, and this should be very basic, but also at the same time try and pull together just some really concepts on what epilepsy is, and hopefully maybe what it's not. So we'll just go through and define epilepsy specifically, talk about how seizures are classified, because there's all different types of seizures, different types of epilepsy, and many of you may or may not have heard of these different types. And then we'll go through some of the diagnostic tests and things that, how do we determine if somebody does have epilepsy. Nobody's paying me to be here. So what is a seizure? This is a technical definition, but what it comes down to is there's an area in the brain, or maybe the whole brain itself, that gets hyperexcitable. So these neurons or these brain cells become abnormal, and there's a surge of electricity that occurs. And the seizure is actually what you see as well, and there's different ways that seizures manifest. So it used to be called, and before we knew a little bit more about it, this is sacred disease. There was some mysticism or some spiritual connotation. You've heard of the terms grand mal and petit mal or petit mal, and these are terms that are descriptive of possibly some demons, or also with some types of seizures you get these experiences, enlightenments, or visions. So that was before it was really understood. But even before that, Hippocrates, this kind of father of modern medicine, said, it's probably not so sacred. It probably has just a natural cause like anything else. And we shouldn't necessarily, it won't be considered divine when we fully understand it. So let's see if we really understand what it is now. In fact, just last year in 2014, the International League Against Epilepsy, it's this international group of doctors who decides, what to call things, what is a seizure, and we've come up with this definition, really. So it's a little bit small here, but if you have two seizures that are otherwise unprovoked, meaning that there's no other explanation for it, and they're 24 hours apart, you could be diagnosed with epilepsy. The other one is, this is a new category, is you can get you can be diagnosed with epilepsy even after a single seizure, and that is a new concept. The change is if you have the likelihood of having a second seizure greater than 60% in 10 years, then you would fit that diagnosis. There's also, you can have just a single seizure, or you can have these syndromes. There's different, people may have heard of Lennox-Gastaut syndrome, Dravet syndrome, West syndrome. There's different types of a constellation. It's not just seizure, but there's a lot of other body parts and organs involved. But also with this new definition, you can be considered seizure-free or actually have that diagnosis taken off of your medical records if you have one of these childhood syndromes that you've been seizure-free for 10 years and have been off medications for 5 years. So there are some technical components, but those are the newer definition of epilepsy. So how common are they? Very common, seizures. But a seizure doesn't necessarily mean that you have epilepsy. And up to 10% of patients might actually have a seizure in their lifetime. So epilepsy affects about 1% of the population and worldwide. And there's 150,000 cases, new cases, that are diagnosed every year. So who gets seizures? When do they occur? And you can see at the bottom area here, this is how old the person is. And this is the likelihood of them having seizures out of 100,000 people. So it's the disease or a state that affects primarily when people are born or are being developed. And then the chance of having epilepsy or developing epilepsy really declines. And then after the age of 65, it really escalates again. And so somebody might say, well, why am I developing epilepsy? I'm 60 years old or I'm 70 years old. Isn't this a childhood disease? And the reality is there are more tumors, strokes, so bleeding in the brain, head traumas, things that occur later on in life that cause seizures. But it does depend on how old they are. So a newborn might have their brain might not form properly, or they might have lack of oxygen, such as what was the case in the video, that lady describing her pregnancy. There's also brain hemorrhages or bleeding in the brain. In children, they might have a fever, might have a meningitis or encephalitis, some type of brain infection. And then in the adolescents and young adults, head traumas, car accidents, skiing injuries, rock climbing injuries. So, but there again, infections. And interestingly, a statistic with autistic patients is it's very common in patients with autism. And then there's obviously genetic factors as well. Older individuals with stroke and tumor. And even neurodegenerative conditions like Alzheimer's. It's more common to have seizures. And so this is our understanding of epilepsy and what causes epilepsy. You can see, and this is a paper in 1975, what we understood about seizures and what caused epilepsy. And on the right is what we think and now understand in 2014 and moving forward. So we still don't know. There's a huge category of seizures that we don't fully understand. I mean, we understand the tumors and the infections, stroke, trauma, but there's just a very, very large area of this pie chart, the things that we think are genetic mutations or environmental factors possibly that cause seizures, but we simply don't have that pinned down. So just to change gears a little bit, so there's different types of seizures and different types of epilepsy. And I think this is very, very important for us to understand and to know. There's two broad categories, one we call focal seizures, and the other one generalized seizures. And we'll talk about these individually. But there's several different types of focal seizures and several different types of generalized seizures. And we'll discuss the difference. So we'll start with focal seizures. These are seizures that start in one particular spot in the brain, or they have a focus. And they're broken down into focal seizures where you don't lose consciousness and seizures where you do lose consciousness. So these seizures where you don't lose consciousness, we call them auras. Some people have a sensory phenomenon, such as their arm might go numb, or their arm might start to, or they might have this déjà vu-like sensation, or the opposite of déjà vu called jamais vu, where you go into somewhere very, very familiar, like you go home one day and you become very confused. The nurse that was talking said that she had an abnormal smell and taste. So those are all auras. That she didn't lose consciousness per se. There's motor seizures where the muscles might start to jerk or twitch. And those can be simple or complex movements or more purposeful type movements, and not necessarily just the jerking and twitching. Autonomic refers to how the body automatically should function, but some people have this panic attack come out of nowhere and their heart starts to flutter, or they get goosebumps out of nowhere, and that could actually be a partial seizure. They don't necessarily have to lose awareness. Obviously, everyone that has a panic attack is not having epilepsy, so don't get a bad idea. So with the seizures that people lose consciousness, there's a new term that we use called a dyscognitive seizure. We'll talk a little bit about that. And then there's seizures that start in one spot or have one focus in the brain, and as they progress over time, it actually can turn into a larger seizure, a full body or a generalized seizure. And I put this slide up just so you can appreciate the brain has many different functions. And if a focus of the seizure, if it occurs in this particular area, for example, here on the top part of this temporal lobe, somebody might actually just hear a sound or might start to have a familiar music or a song play over and over and over like a broken record in their head. So that could actually be a small seizure if it hit that area of the brain. Another seizure might occur in this red area up here in the frontal lobe, and that might stop their speech, or you can think fine, you just can't get the words out, and it's as if it seems like the patient might even be having a stroke, but it could be simply a seizure. If it occurred in the back part of the brain, you might have some type of visual phenomenon like spots and sparkles or zigzaggedy lines. People get that with migraine headaches too, so there is some difficulty to differentiate those. I had a patient that had a seizure in this area, this purple area of the brain, and every time she had a seizure, she felt like the sofa in her living room flipped upside down. So a visual spatial phenomenon can be disrupted. So these seizures that lose consciousness, this kind of new category called dyscognitive, you've hopefully heard of the term complex partial seizures. This is a term that replaces that, and these are all just doctor terms. So if you say I have complex partial seizures, that everyone's gonna, doctors are gonna understand that, but not a lot of people are using the term dyscognitive, but that is the newer term that we use. So if you will lose awareness with these seizures. I'm not exactly sure what happened to that. Yeah, right. The computer just had a problem here. There you go. So these dyscognitive seizures, we'll get that going, is where you are actually going to lose awareness. You might start with a partial seizure, like abnormal taste or smell, and if the seizure does progress into something larger, then you can start to, people function actually. They can be walking around, they may have even some type of interaction, but you just won't see any, they just won't remember. Okay. Usually lasting a couple of minutes, these seizures. The other category of these seizures is called secondary generalization. So if you do have a seizure that progresses, even it might be a dyscognitive type seizure where they lose awareness. But it progresses to the state where you start to have a full body convulsion. Another term that would be commonly used is grand mal type seizure. So it could start as a smell, taste, progress to losing consciousness, and then even go on to having a full-blown grand mal or a generalized tonic-clonic seizure. So those are the main types of the partial seizures. Hopefully this will stick. So here's just an EEG of a focal seizure or a partial seizure, and where the red arrow is, this is where the seizure starts. You won't be professional EEG readers, but you can definitely appreciate here's the kind of the background brain activity, and then you can see this abnormality starting, and this is actually the right frontal lobe. And as the seizure progresses, it starts to get more, recruit more and more of the brain. And as it generalizes or actually goes to the other areas of the brain, you can see that it starts to spread throughout. So those are focal seizures. And we'll talk briefly about generalized seizures or generalized epilepsy and the various different types. You may have heard of absence. Another name for this is petit mal seizures. So somebody might actually say they have petit mal seizures, but that term's being misused. And that's often what we do see in our office. Myoclonic seizures, atonic and tonic-clonic, and we'll talk about these. So absence seizures are very brief staring spells. And this is what's occurring in the brain, is the whole brain itself is having this big electrical surge, kind of like my computer just a few minutes ago. So, but they last 20, 30 seconds, and then the person's back, completely back to normal. And these are more common in children, and you can, quote unquote, outgrow this type of seizure, and not always. But the kids or young adults are normal developmentally. They may have some challenges because they're missing 5 or 10 seconds of somebody's talk, and they have to catch back up. But developmentally, they should be normal. So this other type of generalized epilepsy is myoclonic, and there's a certain term of a juvenile myoclonic epilepsy. Is a very specific epilepsy syndrome, where the body just has these sudden brief jerks or twitches, and that is their seizure. They can cluster, and then they can actually progress as well. Another category of seizure is tonic and then atonic, and the EEG pattern is very similar. Tonic seizures is a tonic contraction, so your muscles contract and you're just stiff. And then atonic is just the opposite, where you see these drop attacks. You see these adults or children, and these are the ones that actually need to be wearing helmets, soft helmet or a hard helmet, and they'll just drop to just completely lose tone in their body. So there's also these quote-unquote grand mal seizures we call generalized tonic-clonic seizures, where the whole body convulses. There's no warning. There's no smell. It's not a focal onset. It's the whole brain is surging both sides of the brain are surging, and causes people to stiffen, fall, shake, foam at the mouth. And those are the kind of the typical seizure that people think about when they think of epilepsy. Is just a very, very small portion of actual seizures. So how do we diagnose seizures? And to be honest, of all of these things that are on here, the number one important thing is that you give a really good, detailed history to the physician. And history is so very important. If you go see an epileptologist, most of the hour-long visit, or however long you have time with the doctor, is just going to be talking about your history. What happened? Has this ever happened before? Have you ever had any sense of recurring deja vu? Or so a lot of it is in the history, and the neurologic exam can be very helpful as well, to make sure that if there is any difference between the right and the left side of the body, and there are some very subtle things that the neurologist or the epilepsy doctor will be able to pick up on. Because of not everything is epilepsy, we need to make sure that drug screens are checked. People are doing things they shouldn't, and when those, for example, even something like alcohol, when it wears off, then the body or the brain can become hyper excitable or have a surge of electricity, and you can have a seizure. A spinal tap isn't typically necessary for a seizure unless there's a fever or any suspected type of brain infection. And EEG and MRI are very important as well. So just some of the testing, I'll show brief examples of this. So EEG looks at the function of the brain. It doesn't tell me what it looks like physically, but it tells us how it's functioning. And if you can see on this page here, there's in the left temporal area of the brain, we call it a sharp wave, and it's sharp, it looks abnormal, it stands out, and that actually is a signature that's probably where the seizures or the epilepsy is coming from. MRI and neuroimaging is helpful. We need to look for brain tumors. We need to look for scars. There's a condition called temporal sclerosis. We need to make sure that the temporal lobe is okay. bleeding in the brain, all of that will show up on the MRI. fMRI tells us more about the function, how the brain is functioning through different tasks. There's PET scans, which is a metabolic type test. And Dr. Taub will go over a lot of these tests in more detail, so I'm kind of just introducing the concepts to you. SPECT scans, which is a blood flow test, and then there's magnetoencephalography, which some people may not have heard of, checking small magnetic fields from the brain. So a functional MRI is you lie in the MRI and you do some type of task. For example, move your finger repetitively up and down, and that causes an increased amount of demand on the area of the brain that you're able to do that function. So if the right finger's tapping on the left side of the brain, there's going to be a certain area that's activated, that there's going to be increased blood flow, and the MRI is able to actually check and see the difference in the brain flow, or the blood flow and oxygen level to that area. A PET scan is that you get an IV and they inject a radionucleotide tracer, and that is taken up by the brain. And if certain areas of the brain are not working properly, then it'll look different. And in this particular scan, it's hard to appreciate, but in the temporal lobes, there is decreased uptake of that tracer. So there is some problems with this temporal lobe. A SPECT scan is similar. You're injected with a radionucleotide type material, and the tracer is either taken up or not taken up. In this particular scan, this person had a seizure, and they did the injection, and then they checked the scan afterwards, and this is where the seizure was affecting in the temporal lobe. Magnetoencephalography is when you have an electrical activity in the brain that creates a magnetic force or a magnetic field, and these specialized devices will be able to pick up that magnetic trace, very, very tiny magnetic field. This is kind of what some of the data that you get. It looks a little bit different than an EEG. And then if you have a 3D reconstruction of an MRI, you can actually find out exactly where those spikes are occurring within a few millimeters, which is a very, very accurate test. A lot of these tests you're not going to do just to diagnose epilepsy, but are going to be if you have a focal epilepsy, and if you're considering surgery for that epilepsy. That's why you would have most of these specialized tests. As far as questions that we get, number one, if somebody has a convulsion, was this even a seizure or not? Was it a seizure from something else? Was it an epileptic seizure? Was it provoked or unprovoked? And if you have the definition of epilepsy, it's typically an unprovoked seizure, meaning there's no other cause for it. Is it focal or generalized? What type of testing should be ordered? Do you need to start treatment? Should you start drugs? Is there, diet? And we'll hear about different treatments from Dr. Dempster. So, what else? If somebody has a convulsion, what else could it be? They could simply have passed out because they had an irregular heart rhythm. And sometimes when patients pass out or fall to the ground, you can have a brief convulsion, and it looks like a grand mal seizure, but it's actually just because the heart stopped, and not necessarily because it was an abnormal surge of electricity from the brain from an epileptic seizure. Stroke, low blood sugar, even certain types of migraine headaches, you can get stroke-like symptoms, seizure-like symptoms, and it doesn't necessarily mean that you're going through it and having a seizure. One thing that we see not uncommonly is psychogenic seizures. And so somebody may have been diagnosed with epilepsy where they actually have more of a psychiatric or a psychological condition. And some people have both. But some people have seizures and they're doing it on purpose because they want attention, and that's called malingering. Other panic attacks, intermittent explosive disorders, people have bouts of rage. You can get that with seizures, actually, but breath-holding spells in children. Some kids will hold their breath so long that they pass out and might have a convulsive activity, but it's because they held their breath. So I do want to talk briefly about these psychogenic spells because they are so common that we see. they're called conversion disorders, where a patient usually has some type of post-traumatic stress and they're unable to express their emotions verbally. So it comes out into a physical symptom, and it can come out into a seizure, come out as a seizure. So about 50% of patients, once that is recognized, you're able to treat it through psychotherapy, through talk therapy with the doctor. You can have epilepsy and non-epileptic spells as well, and that gets a little tricky. And you really do need a video EEG test or an epilepsy monitoring test to sort through that. And there'll be more talks about specific treatments and testing, but an epilepsy monitoring unit is a specialized unit in the center. We have one here. There's somewhat Legacy, Good Sam. There's the different centers that have these epilepsy monitoring units, and they're very important. And they provide video and EEG capabilities. So we're watching the patient and recording EEG at the same time to see if the spells that they're experiencing, to find out if they're epileptic or not. And although EEG is not 100%, and we do miss some things, it's a really good test to differentiate. And also we're able to recognize seizures that the patients don't recognize. For example, we talked about those dyscognitive seizures where patients don't remember or don't know what they're going through, and you can capture those and patients aren't able to recognize. And also, if we're going to do any type of surgery, they absolutely have to have this type of test. So just a couple things to finish up. This is one particular study of over 200 patients that were recorded in these epilepsy monitoring units, and 20% of these patients had just psychogenic spells. And these are patients that had been treated as if they had epilepsy for up to 9 years. And half of them were taking 3 seizure drugs at the time when they had this seizure evaluation. So because something looks like a seizure doesn't necessarily mean it's epilepsy. And it's very, very important to sort through that. I mean, these people, 9 years of being on medications, and they don't even have epilepsy. That's very, very significant. Another important thing about the epilepsy monitoring unit is that out of patients that had seizures, only 30% of them, or 30% of them said that, no, I did not have a seizure at all. And so they felt that, no, you're mistaken. I did not have any, but you can see it on the EEG. And only 23% of patients were aware of all of their seizures. So if you have seizures, or if you have epilepsy, or if you know somebody that does, that's a scary figure, because patients that have epilepsy may not be recognizing all of the seizures that they are having. In fact, in this study, only 23% of them actually recognized all of their seizures. So just in summary, we just went over a broad definition of epilepsy, either having 2 seizures with no other explanation, having 1 seizure with a likelihood of having another seizure in the next 10 years of greater than 60%, or having one of these epilepsy syndromes. And then we talked about the difference, these 2 broad categories of focal epilepsy or focal seizures and generalized seizures. And it's really important to separate those because of what Dr. Dempster is going to talk about with treatment. And the evaluation and testing, EEGs, MRIs, PET scans, SPECT, WADA, these are MEG scans. So these are very important tests that we can do. And so our goal is no seizures, right? But at the same time, we want to help patients with their quality of life. And that's really what it's all about, is if somebody does have epilepsy, it does need to be diagnosed properly, because a lot of people that are having seizures, well, let's say some people that are having seizures are not having epileptic attacks, and that needs to be important. That's important to differentiate. So I just want to briefly answer any questions. We are going to have a question-answer session later on in the day, but please feel free to ask some questions. I think, Raylan, do you have a microphone or? Okay. Okay, yeah, great.
I had a question where you said they had been diagnosed and on meds for 10 years and they didn't have seizures.
Yes.
I mean, how did you know they weren't? I mean, was a EKG given when they were first diagnosed and it looked like there was activity?
That's a really good question. So if somebody has had the diagnosis of epilepsy and actually not had a true epileptic seizure, one of the really important parts of being a physician is trying to determine if somebody has an epileptic seizure just on the basis of history. And before 1950, we didn't have EEGs. We didn't even have the technology we didn't even have CAT scan, we had no MRIs. I mean, we have a lot of technology now that we didn't have. So somebody may have been diagnosed with seizures years and years ago with possibly not even any tests, which would be very surprising nowadays. But, and EEG can also be misinterpreted. There are certain spikes that can be actually normal variation on the EEG that could be misinterpreted by somebody that's not a specialist in epilepsy as an epileptic spike, which in fact it's just normal.
So if an epileptic doctor did an EKG and saw the seizures, it's likely they're correct on that.
If you were connected to even just a simple EEG, 20-minute test, and we saw epileptic spikes combined with your history of seizures, yeah, you have epilepsy. So I don't want to say that people, you don't have epilepsy. No, that's not the case. But if you do happen to go into these epilepsy monitoring units and we see these abnormal spikes and actually record one of the seizures, that's the definite epilepsy. Yes.
Of the 23% of the people that didn't recognize all their seizures, did these seizures run the range of seriousness, or were some of them seizures that might not have had any impact on them in their daily lives anyway?
Good question. So that 23%, that statistic was one particular study, and it was a study of about 30 patients. So it's small sample size, but at the same time, I think it does actually, it's a pretty good representation. And if somebody has a grand mal or a generalized tonic-clonic seizure, they usually know about that. But so the gamut of seizures, they're usually subtle seizures where a brief, even 2 or 3 second staring spell, or these dyscognitive or complex partial seizures that we talked about. Those are usually the ones that we're talking about. But that brief interruption of consciousness is enough to cause a car accident. So that, in fact, would disrupt their life. If you're sitting in your office or at a desk, or if you're home doing something and you have a 2-second seizure and you don't know it, probably not disrupting your life, but still concerning. Yes, please.
All their seizures, was it not?
The statistic was that 23% was the patients that were fully aware
Of all their seizures.
of all of their seizures. So conversely, the over 70% of patients are the ones that did not. Correct. Thank you for
We have
clarifying that.
someone with a question.
Can you have many different kinds of seizures? Like I have a teenage son who has tonic-clonic seizures, but I also notice that sometimes he kind of stares off, or he'll, just something is not quite right.
Sure. So
He's not aware of this at all.
So there are different manifestations of seizures, and it's important to do the EEG to determine if it's a generalized or a focal seizure. But if a focal seizure spreads to different areas of the brain, that can turn into a tonic-clonic seizure. If it's just a smaller seizure, it might just be a staring spell, but the actual onset of the seizure is in the same place. It just doesn't spread to the rest of the brain, which causes the harder or bigger symptoms. But there are different types of seizures, and a given individual may have different types. It is important to differentiate the type, because some people actually, not particularly your son, but some people might have epileptic seizures and non-epileptic seizures as well. And so it is important to differentiate the different types.
My son, he has complex partial in the parietal and temporal lobe, and he's 8. He sees colors, and then will have a headache. And how do we know if he's out there and he doesn't know to tell us he's having a seizure? Like, how do we know if it's migraines or seizure related?
Right, that's a good question, and there are certain types of epilepsy syndromes that kids will get migraine headaches and just start throwing up, and it's actually a seizure. So it's a strange kind of complex. But if you know that he has temporal and parietal seizures, it depends on if the seizure starts there and spreads to different areas of the brain, then you would have some type of visual phenomenon. Can turn into, you can also have, migraine headaches are very common in patients with epilepsy, very common. And so how do you know if he's having one or not? It can be a little tricky, and that's why we do have these monitoring units to try and differentiate, is this seizure, is this simply behavioral, is it migraine? And that's really the best way to differentiate, is to actually record these with the video and the EEG at the same time.
My name's Angela, and our daughter has cerebral palsy and epilepsy also as a result of the brain injury. And my question for you is, have you ever heard of the Alice in Wonderland syndrome?
Yes.
Okay. And can you just say anything about that? I just want to say that that's how I knew that something was going on with her neurologically, that she was experiencing things in kind of a time warp fashion. Okay. And maybe what is another name for that? Because her neurologist was totally unaware of
okay,
that.
So the question is about, have I ever heard of Alice in Wonderland syndrome? And if you've watched Alice in Wonderland, you see that Alice eats a cake and becomes very tall, and then eats something else, becomes drink this, becomes very small. So it's this kind of a physical distortion or a distortion of reality. And Lewis Carroll, who wrote Alice in Wonderland, actually had migraine headaches and possibly partial seizures, but the migraine headaches affecting that particular part of the temporal lobe, causing this kind of this distortion of proportions. And we do see this rarely with focal seizures. So it would be a focal epilepsy diagnosis if, in fact, you recorded that it had an EEG correlation, because it could be, your son with cerebral palsy has the epilepsy. Those are the experiences that he has. So it is documented. We do know about it. What's another name for it? Would just be a focal seizure.
My daughter was on Dilantin for around 30 years. No problems with it, but I keep hearing that there are a lot of side effects with the old Dilantin. Could you explain that?
Sure, and I think Dr. Dempster will go into a little bit more detail with medications. But Dilantin is one of the older medications that we have, and it's a great seizure medication. To be honest, it controls seizures very well in a lot of patients, if it's the right type of seizure that's been diagnosed. But it does have long-term side effects. And one of the big ones that we know about, there are some birth defects in women in childbearing age if they have a baby, but there are also long-term side effects from osteoporosis. It can affect your liver, it affects your gums and your teeth. So sure, there's all kinds of side effects that, we're not big fans of Dilantin in the long term if there are other safe alternatives.
I have a question. I have a son who is 10 years old. He has fires. And going back to the intermittent explosive disorder.
Yeah.
I mean, can that go hand in hand with seizures? Because he suffers multiple seizure types. He's intractable epilepsy. But he has these outbursts on occasion. And then sometimes he's aware of them, and other times he's completely not aware of them.
So just briefly touch on that, and we can talk about a little bit more in the question-answer panel with some of the other questions. But the intermittent explosive disorder is kind of like a rage, and it's more of a psychiatric condition. But in particular, patients with epilepsy and frontal lobe epilepsy. So if you have a certain area of the brain that's activated, you become you can have these kind of rage attacks. And it doesn't necessarily, but everyone that gets upset and goes into a rage doesn't have epilepsy. But in particular, some people, as a manifestation of their seizures, can have behavioral disorder.
Okay, that was just a question.
So we will pass the time to Dr. Dempster.